say that I think it's really exciting and that we are having this webinar now, which builds on a lot of the more recent discussions about early treatment, early testing and early treatment for infants. I think this builds on a lot of the discussions and exciting evidence that emerged out of IAS 2017. And it's also very exciting because Mozambique has been one of the countries that has been an early adopter of point-of-care HIV diagnostics. And this particular example that is being discussed here today is made possible through the funding and support of UNITAID through a project implemented by the Clinton Health Access Initiative and UNICEF. So without any further ado, I'll turn it over to Bindia to take us through her presentation.
Thank you, Jessica, for your introduction. So I will start. So as Jessica said, my name is Bindia Megji, and I will be doing this presentation on behalf of Instituto Nacional de Saúde and Clinton Health Access Initiative. So we conducted this study that I will talk about in Mozambique in late 2014 until 2016, and I'm going to talk about that. So as a background, we all know the early infant diagnosis with centralized labs has their own issues about long turnaround times and other logistics issues. And that can take some delays, I will say long delays on putting HIV positive kids, infants on treatment. And also the peak of HIV-related mortality rates occurs even before the results are given to the care giver. Currently, we all know that our point-of-care availables for early infant diagnosis that are pre-qualified by WHO. And we here in Mozambique also conducted a pilot study to show the effect of using those point of care in some clinical outcomes. And we could show that at 4 to 6 weeks, they really have an impact on treatment initiation rate and retention. So WHO recommends adding nucleic acid testing to the current EID strategy that is the 4 to 6 weeks in Mozambique. So at the time that we conducted the study, we needed some data on the performance of the LRQ at birth. We knew the performance of LRQ at 4 to 6 weeks, but we needed to confirm that performance at birth. And also to see the impact, I would say not the impact, but really the benefit of having the birth testing comparing to not having a birth testing. So we conducted this study, which has a primary objective of evaluating the performance of the technology and to show the benefit of using that at birth. The specific objectives were determine the sensitivity, specificity, and predictive values, that is mainly the performance. And the second objectives were to determine the proportion of HIV-infected infants diagnosed by testing at birth and 4 to 6 weeks compared to only testing at 4 to 6 weeks, that is the current scenario in Mozambique. So I will start talking about the methods of the study. This was a prospective observational study that was conducted in 7 maternity wards in Maputo province and in Sofala province. For the performance testing, we used as a standard of care, the conventional was the Roche, and the point of care that we used was the LRQ. Both standard of care and point of care were performed by nurses that worked in the maternity ward. So basically this device was allocated in a maternity ward, not in the lab, and was performed by the nurses using whole blood samples collected from infants less than 24 hours of age. In total, we included 2,350 infants. That was from November 2014 to July 2016. So this is just to illustrate what was the study's design. So the inclusion and the informed consent process was conducted at the maternity wards after 6 hours after the delivery. This was mainly because ethics committee asked us to wait for at least 6 hours to give the mother some time to recover. And then we collected demographic data, and sample collection was done by the nurses. One was for the DBS, and the other one was to test on the point of care. So, but none of the results at the maternity ward was given to the mother. This is because we were also testing the performance. We didn't know if it was working well or not. So no results were given to the mothers. They were informed to come to their routine consultations, postpartum consultation, and then to come also to their 4 to 6 weeks consultation. That in Mozambique we call that child at risk consultation. In Portuguese is CCR, where they would collect again a sample for testing. So during this period, the study team did active tracing and send reminders to the mother to come to that 4 to 6 weeks. At 4 to 6 weeks, there was again demographic data collected and sample collection for standard of care and point of care as well. When we did the study, still we were not using the point of care at 4 to 6 weeks as a routine. So we had to have the standard of care to have a final diagnosis of the baby. In terms of the inclusion criteria, we included infants that were born of known HIV positive pregnant women. Regardless of their PMTCT story, they had to be less than 24 hours of age and whose mother provided informed consent. We excluded from the study infants older than 24 hours, but also we excluded mothers who give delivery by cesarean because we couldn't do the informed consent process because the recovery time will be longer. And also any kids that had a serious medical condition that we could not do a blood collection. So I will start talking about our results. I don't know if you can see properly this flow diagram. So basically we included in the study 2,350. But only 2,328 were actually tested with point of care at the maternity ward. And we identified 37 positives infants with point of care that actually were confirmed with the lab. Only 33 were confirmed by the lab. 2 did not have the lab result, and 2 had inconclusive lab result. We will talk about later about these two infants. For the negative, all infants that were identified as negative in point of care were actually negative in the lab. There was some lab results missing as well. And also we had around 2,058, that is around 11% of invalid results in point of care. I would mention that the error rate at birth was higher than at 4 to 6 weeks. That was due to difficulties in bleeding the newborn, the experience of the nurses on doing that. So the rate really went down during the study, but it was higher at birth compared to the 4 to 6 weeks. Regarding to patient demographic data, mainly all the majority of the mothers were on ART treatment, and when they were at 4 to 6 weeks, majority of the infants were in nevirapine prophylaxis, and they were on breastfeeding. So this, I think someone has his mic not mute. Hello? Yeah. So this is a table just to show the performance of the Alair at birth, and as you can see, it was 100%. Although we have a small sample size of positive infants, that's why we have large confidence intervals. But that was what we could manage to find at birth. So now we will move to how many really infants did come for their 4 to 6 weeks testing. If you see from those tested, included in the study 2,350, we had 41 positive at birth. 41 because we included any valid results. It can be point of care or standard of care. So in total, there were 41 that were identified either by point of care or lab result. From those 41, 9 were lost to follow-up. It means that they never came for their follow-up visit to 4 to 6 weeks or more than 4 to 6 weeks. How we can be sure that they didn't go to other health facilities? So we have a national EID database. So we search for those kids in every center of the Mozambique, and they didn't go to any of them. So that's why we consider lost follow-up. And from those that really came for their 4 to 6 visits, one unfortunately didn't have any valid result. The point of care gave invalid, and the lab result was also not reported. And we were waiting for them to come again, but they didn't. So we could only confirm 29 from those 41 that were already positive at birth. From the negatives that were negative at birth, we had the new 30 positive at 4 to 6 weeks. But as you see, there is high loss to follow-up, around 503 patients that were lost to follow-up. Also, there was 2 new positives that had at birth, they were invalid in both testing. So we didn't know that if they were already positive at birth or they are considered a new positive at 4 to 6 weeks. But in general, we could say that around 50% of the positive tested babies at 4 to 6 weeks were already positive at birth. And adding a birth testing, we can increase 16.4% of patient yield if we add birth testing. So that shows really the importance of the birth testing. So now I'm going to talk about those 2 patients, and more too that they were really special. So this is a table with 4 patients that tested positive at birth, either with both point of care or lab or just point of care. If you see patient number 1, he tested positive with both point of care and lab. And when they come around 1 month after, their point of care result was negative, but the DBS was rejected due to quality. But they also came, we called them back. They came back afterwards around 4 months, and they tested back positive in both point of care and lab. In patient number 2, the process was similar, but in this case, the negative was a lab result, and then they come back again and they gave positive. So you see this patient number 1 and 2, they really has a negative result at 1 month, and they come back as a positive. For patient number 3 and patient number 4, they gave positive in point of care, but the lab gave a very low positive result. So they considered it invalid and asked for a new collection. But in that case, a new collection was not applicable because the baby was already gone when we received the information from the lab. So when they came after 1 month, the result was negative. So we called them back to come again to test, and they were again negative in both scenarios. So in these 2 patients, they were positive at birth, but then consequently they were negative until the time that we could manage to follow up them. So this is our 4 special infants that has some differences. So our ideas are that the transit negativity at 1 month could be due to the nevirapine prophylaxis. This has been seen in other studies as well, but we are not sure what can be causing that. And regarding to the patient number 3 or 4, it really shows that we need to do some confirmatory testing, or maybe there was something happening for these 2 patients that need to be studied more. So in the conclusion, we demonstrated that performing a point of care in maternity wards by nurses is feasible and accurate. And we also showed that birth testing in combination with routine 4 to 6 weeks can increase access to EID. But confirmatory testing of the positive should be implemented to make sure that we have a reliable testing. And also I would add that some more studies should be conducted regarding to the in our study, we really didn't give the result at birth, but if we could give the result, we should have a package of counseling to ensure proper retention for those who tested negative, to make sure they came, because as you know, as you see in our studies, there are many who became positive after the birth. So it's very important to make sure that they come to their 4 to 6 weeks. That's all. We would like to thank our study participants, the staff, and the laboratories, and also to the funders, the UNITAID, who supported this project through CHI and UNICEF, and also Governor of Flanders, who co-funded this study. Thank you.
Thank you so much, Bindia, for a very insightful and innovative presentation. We have a few questions coming in, so I'll go through them. I'd like to ask that everyone please keep your phones on mute. I can see that some of you are unmuted, so please ensure your phone is on mute so we have no interference. Thank you so much. So I think some of the first questions were revolved around were the positive children at birth started on treatment, but the results weren't shared with the mothers and caregivers. So I think the question that comes into play is, what was behind the decision not to share the results? So that's maybe the first question, and then we'll get to the others.
Okay, so in the time that we started the study, we didn't know the performance of LRQ at birth, so we couldn't give the result at that time. But the thing that we managed to do is that when if we know that the baby was positive because we have access to the result, we make sure that we do active tracing. And when they came at the 4 to 6 weeks, we did a fast testing for them. So we already knew, we informed the nurses at the PMTCT clinics that this is a potential positives. So rather than calling after collection, calling the baby after 1 month, they were called after 3 days. So we made sure that the samples was tested as soon as possible, so they could start the treatment as soon as possible. So that was that's what we did at that time. Of course, afterwards, the point of care became routine in 4 to 6 weeks. Then they had a confirmatory 4 to 6 weeks at that moment, so they didn't wait for a lab testing. So the decision was made because we didn't know the performance of the test at that moment.
Great. And linked to that, were the children who were lost to follow-up, whether positive or negative or invalid, having invalid results, were they physically followed up?
So I don't know what we mean by physically followed.
I mean, I think perhaps the manual can specify, but I think it means like if there was a home visit or somebody going out. And perhaps that's what's meant by active tracing, but yeah.
Yeah, so active tracing was if they had, because the thing is that depends on if the mother will to give a valid and true address. So what we didn't do in the study is that we didn't confirm during the inclusion if the address that they give was a true address, okay? So active tracing was trying to call them on the number they gave, try to go to their houses from the address they gave. So the main problem is that people tend to lie about the addresses, about the telephone numbers. So it was very difficult to trace those infants.
Okay, thank you so much. Yes, I think that's something that's observed in different settings, that due to maybe stigma and discrimination, there's a fear in revealing your real address. So thank you. Next question is, yes, that it's a very revealing study, and this is from Ravi of CDC Atlanta. Have the children been followed ahead for viral load testing?
No. They were not followed ahead for viral load testing, unfortunately.
Okay, great. And the next question is from Precious Robinson in South Africa, who asked, were the mothers advised to still continue with prevention measures after delivery? Was there any counseling provided to the mothers?
Yes, so the counseling was provided, nothing changed, so they were counseled to do all the things that they should do and to come or to their visits, to do whatever they would do, even if there was not a birth testing. The only thing that we didn't have in our study is, because we were not giving the results, is the counseling for those who tested negative. So this is something that we plan to do, but the counseling package was continues to be same as they were not tested at birth.
Okay, great, thank you. And then the second question is from Precious is, were the nurses in the maternity wards trained on DBS testing before engaging them in the study?
Yes. So this was very interesting during our training, because the maternity ward nurses, they are not used to do DBS collection. So the training for them was very intensive. First, they needed to be trained on DBS collection and also to do testing. So,
sorry, yeah. I think go ahead. Mm-hmm.
Yeah. So the error rates, especially in the DBS as well, is high in the maternity because of that inexperience of the nurses. So they started getting better during the study, but they had, even after the training, they were not used to do that in their routine. So there was a issue on the quality of the DBS and everything in the beginning.
Okay, great. Thank you so much. And then any indication on time to ART initiation from the testing time for the positive cohort?
No, I would say we didn't collect that information for this study.
Yes, but there was a previous study, correct, done by in Mozambique that measured.
Yeah, the pilot examination, 4 to 6 weeks. That was collected on that one.
Mm-hmm. Great. And we're happy to share the information that's been published about that study if it's of interest to the participants. And then another question from Emmanuel of UNICEF Malawi. Were the errors due to the sample volume or to the point of care device and machine itself?
So I would say it's not always due to sample volume. It's sometimes errors of the machine. But if we compare the error rate at birth at birth was 11%, and at 4 to 6 weeks was around 3 or 4%. So I would also say that the blood volume could be a problem as well, because they struggle to pick the babies and draw blood from the newborns. So also an experience of the nurses on drawing blood from the newborns, and maybe other factors to be like being a newborn, there is a contamination maybe. So the error rates were not, there were different types. Could be the sample volume, because it was hard to have enough sample, even though the alert needs only a small amount of blood, but also due to the processing and other aspects. So there were different type of errors, but something is in at birth, the error rates were higher compared to 4 to 6 weeks.
Okay, thank you. And another question from Hafsa of UNICEF Tanzania. What was the rationale for the inclusion criteria being less than 24 hours after birth?
So one thing would be that in our maternity wards, the mother doesn't stay more than 24 hours. So if we want to have those babies tested at maternity wards before they leave to their houses, we had to have before 24 hours. Another aspect was that we wanted to associate this to early treatment. There have been some data showing that if we treat the baby before, even before 24 hours, we could get to really, I would say, the cure of the baby. But as we know, it's just ideas. So that's why we wanted to implement something that would be feasible, as the mothers are still there to be counseled and to be tested. And also because we wanted to associate these to future trials of early treatment and possibly cure.
Okay, great, thank you. And a suggestion or kind of a question about the training. Did the training include mentorship so that there's better outcomes post-training, and that the nurses in maternity wards are become more experienced and skilled at taking DBS samples and performing early testing of infants? So did it include any mentorship, or is that something that you're considering?
No, the study included mentorship and monitoring. So we had weekly visits, refreshment of the training, Also, we had nurses from PMTCT clinics coming and showing them how to work. So there was a whole package and monitoring of all the activities. That's why they got better after the study initiation and when they started to use it.
Okay, great. Yeah, thank you for that clarification. And a question from Olusola in Nigeria. What are the resources required to operate the point of care machine in terms of electricity and consumables?
So in terms of electricity, the alert device has an internal battery that can work at least to finish the running testing. But they also have external battery. If it is charged properly, it can stay until 8 hours. So you can have a full day of testing without electricity just based on the battery of point of care. Regarding to the consumables, you need only there is a cartridge where you put the sample, and you need a lancet to pick the baby finger or the foot or the heel, and also the other biosafety consumable like other stuff to clean and other things. So basically for the testing properly, you only need the cartridge and the machine, and then you need a collection kit to ensure you can collect the sample. So the sample is, you can prick the baby and put directly the sample into the capillary tube that is in the cartridge of the study. This is for alert cure, what I'm saying.
Okay, great. Thank you. And the last few questions, this is from Lori Goulet of UNICEF Regional Office in Nairobi. As the results were not given to mothers at birth, am I right that this study could not assess the impact of birth testing on the return for 4 to 6 week testing?
Yeah, so basically, as we didn't give the result, we didn't access any impact of testing at birth and the return at 4 to 6 weeks. So the only follow-up and loss to follow-up are based on not knowing if the results were negative or positive. So basically, our study couldn't access that.
Okay. And last, were the error rates noted in this early on in the study or throughout the study period? So could user proficiency have been a contributor to the error rates? So do you have a sense of were there more errors early on in the study and then it decreased over time?
Yeah, that's I mentioned.
Yeah,
so
yeah.
it was higher in the study initiation, then it got better. But even though it was higher than 4 to 6 weeks. Another aspect is that the error rates were not only at point of care side. Mm-hmm. There was a lot of sample rejected in the conventional arm, around 10%.
Okay, great. So if there are no further questions, please everyone feel free to send in more questions if you have. Bindia, I know the studies are very, they're early results, and the study was a very specific study. But do you feel that there are any kind of early lessons learned and that can be applied to programs, or another aspect might be, are there any, if you were to continue the study or do the study differently, are there any things you think that other countries should take into consideration?
So I would say that our study, when we started, was 2015. We wanted to mainly to see the performance, but also to see really if there was really, I would say, if birth testing could really increase the number of positive kids that we would identify early. for now, I think other countries and even Mozambique, we wanted to start implementing birth testing, but there was some worries from the HIV program that came out. For example, we need some acceptability studies because we want to know if the mothers are willing to know their status of the babies on the day they deliver, if all the social aspects of testing at birth, and also now as I recently saw that South Africa has seen a decrease on infants coming to their 4 to 6 weeks, and that is not a good happening. So I would also make sure that a counseling package should be properly created to make sure that those infants that are tested negative understand that the mothers understand that doesn't mean that they will stay negative forever. And other counseling package should be tested to make sure that it's effective in retaining those kids. So generally, I would say these are our ideas, and starting the treatment as soon as they test positive at birth, ideally before 24 hours. We also plan to do that to see the impact also for those who's tested negative, but their mothers has a high viral load during the delivery, also could benefit from some prophylactic regimen, a different prophylactic regimen because they were at higher risk. So there are different ideas and things that we could do to help better implementing this protocol.
Great, thank you. I think a few more questions and then we'll wrap it up. This is more about the methodology. Were the lost to follow up infants or mothers mainly the ones with wrong addresses and telephone numbers? And did the participants sign consent with understanding? And I assume that was the case, but for confirmation.
Yeah, of course,
Yeah.
They signed the consent with understanding, but I'm not saying that lost to follow up is because first we checked that they didn't go for testing. It doesn't mean that the mother didn't go for their postpartum consultation. That required us to go to the clinics on all cities to check if they went there or not. So that was not done. What we did is that at 4 to 6 weeks, there is a EID database, electronic database, and we search those kids on that database to see if they tested anytime, anywhere in the country to know the status of the baby. So anyone who went to other health facility that was not the study health facility, we went to the EID database and we collected the results for those babies from that EID database. So the informed consent was signed with understanding, of course, but it's very common for not giving, even someone can say, I don't have a phone number. So there was a very high rate of people saying we don't have a phone number, but we know that it might not be the truth because they were in the maternity ward, they don't carry their phone there because it can be still, and we didn't know. So that was the problem.
Okay. Great. And what other conclusions were drawn about the program based on the positivity rate at birth?
Okay, so the positivity rate at birth is low, but even if it's low, you can really, as we showed, that 50% were already identified at birth. So those kids could benefit. I would say low, but it's not low compared to other settings. Our normal 4 to 6 weeks positivity rate is around 10%. And when I say it's low, I could say it's 1 to 2% at birth. But 1 to 2% is not low compared to other countries. So I would say that the program, you mean the birth testing, we recommend birth testing to our HIV program. The only thing is that they ask for us to have more information on social behavior component. So we don't start doing testing and then suddenly we see that it's impacting negatively the 4 to 6 weeks test.
Okay. And then finally, at what age did you stop following up infants with discordant results?
So in the table, the last time we collected the sample and follow up those kids was it's already in the table. Afterwards, we didn't follow up them because we had to end the study, and they were considered as a negative in the routine care. So we could go back and see if at 18 months they were still negative, but that we didn't know because they can be infected later on for other aspects, and so we decided to stop those kids when they last came to the health facilities.
Okay.
It's in the table. You can see the months, the days of each infant.
Okay. Great. Thank you so much, Bindia Meji, for being with us today and taking time out of your busy schedule at the INS of Mozambique to share your early results, which really show the acceptability and the performance of POC for birth testing. And it definitely indicates some added benefits in the sense of greater yield for HIV testing of infants. So thank you so much. For everyone, the presentation and the recording will be distributed in a day or so following the webinar. So thank you for joining us, and we'll keep you posted on the next webinar. Bindia, any last words or comments?
No, thank you for the opportunity, and hope other countries and we all can manage to solve this issue.
Thank you so much, and thank you everyone for your great questions and active participation. Have a great day. Bye.